Welcome, everyone, to this episode of Shirley Talk. I am Mike Mulroney.
I'm Kelly Duckworth.
And if you're watching the video, Kelly and I are sharing a microphone here today. We've got a group of people here from University of Louisville Health. How are you all today?
We're doing well. Thanks you all for having us.
No problem. Before we start, Kelly and I like to be clear that, are you a doctor?
No.
Nurse?
No.
Pharmacist?
No.
Anything in the medical field?
No.
Yeah, all right. We just want to clarify. So if you hear something, you're not going to sue us. You're not going to send us nasty letters because this is, I hate to say it's for entertainment purposes only, but what else do you call it? It's entertainment, education, and we try to educate our listeners on things related to cancer and stuff like that. So with us today, like I said, we have a group from University of Louisville Health, and you want to go through the introductions real quick?
Sure will. So I'm Dan Deerfeld. I'm a palliative care physician and assistant professor of medicine at the University of Louisville Hospital and School of Medicine. And I'll hand it over to Hannah.
Hi, I'm Hannah Harrison. I am a palliative and hospice fellow at University of Louisville, which means I have completed my medical school training and my family medicine residency, and I'm doing an extra year of training specifically in hospice and palliative medicine.
And I'm Bree Trishan. As we like to always say, I'm the other fellow. I completed my training here at University of Louisville in internal medicine and pediatrics, and then stayed on for another year of training in palliative and hospice medicine.
So combined years of education, what do we have here? How many, Dan?
Let's see. It's 4 years medical school, so we can all say 4 years medical school. I did 3 years of residency in family medicine.
You adding this up? That's 7.
So that's 7. I did then a year of fellowship in palliative care. So I guess we're at 8 years of training.
Yeah.
Yep.
All right, Hannah.
And then I've done the 7, plus I'm in that last year, so we'll just say
15.
add 7
Are you up? You counting? This is 16, I think. So, Bree.
And then I just tack on an extra year for combined internal medicine and pediatrics.
So 7 years plus 1? Mm-hmm. I've already lost count. That's about 26 years of education. How many years you got?
4.
I struggled through 4 myself. So we got 27 years of, so that's the difference between education. Kelly and I have 8 and you all have 27 years. So, it's interesting. I didn't know what the term palliative care meant up until about 6 months ago, to be honest. So what's the difference between palliative and, is it hospice care, hospice care? Hospice is the name. Is that okay?
You got it. So I'm gonna say my piece. I'm gonna see if I've taught the fellows well thus far. So hospice. It's very common to get that question of, am I in hospice care or am I in hospice care? Right. Hospice is the name of our hospice company here in Louisville that provides hospice care. So they did some really good branding and marketing in that, right?
But didn't they used to call themselves hospice?
Hospice of Louisville was
okay.
The old,
yeah, I think
this
really confuses things.
Mm-hmm. But now they've become much larger, and so they incorporate a lot more counties here in the state, and actually over in Indiana too. So they rebranded and now are called Hospice. I hope they don't mind me saying that.
No, I was always confused. We had those folks in here; they're wonderful as well. Right. But I should remember that. But I always ask that question because I just always get the two, and I'm sure the general public does. So.
Oh, they surely do. We hear that a lot, and a lot of clarifying we have to do for them. But I'll let Hannah and Bree talk more about the differences between hospice and palliative care. Yeah.
So palliative care, the root, the palliative part, or palliate, is to help alleviate suffering or symptoms. So palliative care is...
That come from the Greeks or something?
Something like that.
Actually, it did. So it's from the Greek palliare, which means to cloak.
Okay.
And so the whole idea, I guess, of that root term is to cloak. So wrap ourselves around our patients and their families. We are the cloak, and to be what we say is an extra layer of support for that patient and family, no matter what they're going through.
Okay. So that's interesting.
Yeah, so palliative care can extend for several years and can look a little bit different for each family. So it is to help families or patients who are experiencing life-limiting or major life-altering diagnoses. So that can even start like in a pediatric population where they're diagnosed with some genetic abnormality, and they may live for years and years, maybe even into adulthood, but have symptoms that are problematic through their life. So a palliative care team can offer support for symptom management, to help facilitate any type of supports in the community. So that's kind of like what palliative care is, and it can extend for many years to offer support for both the family and the patient, that whole unit.
So you say many years. Could it be 10 years, 5 years? It could be, there's no finite number of years. Because I
Absolutely.
believe hospice care is what, 6 months to a year? Similar, close to that?
So in order to qualify for hospice, you need to have a disease that, should it extend its normal course, would be 6 months or less. Just because you hit that 6-month mark doesn't mean you get kicked out of hospice care. A physician needs to go back out and recertify and say, we still expect that this disease course would be 6 months or less. But that's kind of where we differ between palliative and hospice care.
Okay. Yeah, I'd always wondered how long that palliative would continue. So it's good to hear. So when do you all normally get involved? Is it someone that is like, when do you get involved?
Definitely someone who is facing a serious life-threatening illness or a life-limiting illness like Hannah discussed. At UofL, we tend to get involved mostly when somebody's been admitted to the hospital. We get consulted in the hospital. That doesn't mean that they can't be seen in an outpatient setting. We are working at UofL, we're working towards getting our own clinic so that we can see patients outside of the hospital. Norton Hospital has their own outpatient clinic for palliative care. And then Hospice actually has another division within their company now called Palliative, where they do home palliative care. So they actually come to your home and provide palliative care services in the home. So we like to get people involved or into palliative care as early as we can. That way we can be there with them along their journey and have conversations about what they value, what's important to them, and try to match their treatment plans with their goals and their values. And then, of course, we can be there too when we're nearing that 6-month mark to kind of talk about, is it now time for hospice, and to maybe ease that transition into hospice care.
So what's palliative care look like? Is it helping people with rehabilitation if they might have a chance? Is it pain management? What's it look like? So I'm walking in the hospital and I've got a disease that's probably going to take my life over an extended period of time. Does it include all of that, pain management, rehabilitation, things like that, or what's it include?
So one of our big things is definitely pain management. Other symptoms, often shortness of breath that we deal with, constipation, which can be a huge thing, especially when you're on pain medicine, nausea, vomiting, decreased appetite. More of that rehabilitation part comes from our specialists that, you're working with physical therapy, occupational therapy, and someone who's trained specifically in physiatry kind of takes care of more of that role. So we don't pay as much attention to the rehabilitation part of things, but just how can we control your symptoms to get you feeling as best as you can so that you can get to those treatments that you need.
Get some quality of life while you're dealing with your current situation, I guess.
Absolutely.
You had mentioned before we started about pediatric palliative care. Is there a huge difference? Is it kind of the same? Is it different working with kids?
Yeah, so as far as pediatric palliative care, there is a pediatric palliative care program in this area through Hospice, and it's called Courageous Kids. And they get involved with children at various stages of life. A lot of them do have contact with the palliative team initially through admissions to Norton Children's Hospital. Excuse me. But they can follow them for many years, as I said, help with things like irritability and agitation. Sometimes there's difficulties with feeding or things like that we can help troubleshoot at home. Some of these families really want to avoid the hospital at all costs, and so there can be ways that we can help achieve that goal. And then there is a transition period for some of these patients, especially if it's like a cancer diagnosis, transition to hospice for the pediatric population. And there's something interesting about pediatric hospice where you can continue receiving chemotherapy or treatments, curative treatments, attempt for curative treatments, and continue to receive hospice level of care, which is not the case for adults, and that's called a concurrent care model. So those pediatric kids can continue to receiving treatment and get hospice services as well, which would include a nurse that would visit multiple times in a month, sometimes weekly or multiple times in a week, to help check on the patient, make sure things are doing well. A chaplain that may offer either spiritual support to the patient or to the family, or just be there for another level of support. I've been with a chaplain who this family did not identify as spiritual or religious in any aspect, so they did karaoke together. And then typically a social worker also comes in and helps offer another level of support, and also help navigate if there's insurance problems or extra resources that they need. If they need help connecting with, things around the house, they need maybe a help with building a ramp or to get access into the house. So that is can be offered with hospice and palliative, some of those services.
Yeah, we get that a lot. We've had actually Ford Motor Company. They used to have a crew that would go out and build ramps and things like that. It's interesting you mentioned that. So you probably have groups of people that are willing to help with that, I guess, probably that kind of thing.
Yeah, there's certain people that, like, the social worker has, knowledge of getting people, in contact with the appropriate people.
Yeah. So I'm trying to remember. It's been so long ago. Mom died in 2013, but it seems like when hospice got involved, they said once they're involved, there was you were giving up all medical care and treatments. Is that correct? And that's obviously not the case with palliative care.
Right. Palliative care, we're here with you alongside whatever treatments you want to do. And I think as Bree alluded to, and you, Mike, for both palliative and hospice, I think the overarching goal is quality of life, right? And so in terms of palliative, we're there to try to maximize your quality of life while you're going through whatever treatments you need, right? I know this, a lot of folks think cancer, right? And when they think hospice and palliative, but, both hospice and palliative care teams take care of people with heart failure or end-stage COPD or liver disease or kidney disease, really any life-threatening or life-limiting illness, right? So we're there as palliative physicians and palliative teams to kind of walk alongside you through whatever treatment journeys you're going through. Hospice care tends to be more comfort-focused, maximizing quality of life for what time you have left, and not so much of the aggressive treatments that you had been getting.
Yeah, I'm glad you pointed that out because given what we deal with every day, I just always thought hospice care and palliative care meant cancer, and it's not. It can be any life-threatening illness or disease or problem that you're dealing with.
That's correct.
So my biggest thing, I did my internship with Hospice, the organization, and I remember the biggest part was I live out in the south end of Louisville, and they really wanted me to educate the south end on when people hear hospice, they automatically assume that's the end. So like the last week of life, they'll call hospice in, and that's what you're going to assume. So my thing was trying to educate them on learning, hey, 6 months, or whatever, can you call them? And that way you have 6 months. And some people, like you said, they can get out of hospice care. But is that kind of your thing with palliative? Like, do you wish people would contact you all sooner? Because I feel like you could help them, longer if they would contact you earlier than they should be.
Because your mom never dealt with hospice. She just waited up till the last minute, right?
Yeah, my mom never wanted to hear the word hospice because she was that person. She said, I know that's the end if they call hospice in, and that's not necessary. It more than likely will be, but I seen 2 patients while I was there that actually came out of it because their pain was managed well. They were able to, get better and things like that. But yeah, she never wanted to hear the word hospice because she knew that was the end in her mind.
Not an uncommon thing that we see. I think the last I knew, the average length of stay in hospice is like 2 weeks. And when we're that close to dying, there's not a whole lot we can do to keep you comfortable other than, just medicine, right? And I think that's why a lot of times why hospice gets that kind of bad reputation, right? And I think if we can get people not only involved with palliative sooner, but also hospice sooner, again, quality of life, it will be much better. And like you said, people in hospice tend to do a little bit better sometimes, right? Because we're no longer doing the aggressive, risky medicines and treatments, and they feel better and they do better. And some folks even make it to the point of what we call graduating from hospice, right? So, and then they're able to go on and live life to its fullest that they can. So, the sooner we can do these things, the better.
Do you have an average time that you work with people in palliative care? I mean, you said 2 weeks in hospice care. What do you have an average time of palliative care that you typically work with somebody?
That's tough for me to say because I'm only inpatient based right now.
Okay.
Now in the outpatient world, gosh, that's a great question. I don't know if I have a number. I don't know about you all, if you've read anything recently about that.
From at least what I can speak from our experience, we also work at the Norton Palliative Care Clinic. That opened in 2018. So we have 3 years worth of patients that have been seen there, and there's several patients who have been there for years. There's always new referrals that are coming in. So it's great to see that you're following patients along in their journey. Again, big things are dealing with pain management and those other symptoms that we can help with. We also work with hospice and palliative, and so we've been able to go on some home visits, and so that's part of the community-based palliative care, and a lot of those patients have been enrolled with the palliative care for years, I believe, which maybe you can quote me on. I think that they started in 2019 with the community-based palliative care.
That seems accurate. It wasn't. It was
Smaller.
It was much smaller and much so in development when I went through fellowship. So I did my fellowship training here at UofL as well 2 years ago now. Good gosh. But back then, their hospice's home palliative program was still very much in development, not to where it is today. And now it's more robust, I think, and it's on its trajectory up and doing great things.
So you said you work with Norton and hospice. I mean, that's good. I mean, you see businesses and look at each other as competitors. So is it not like that in the medical world?
It definitely is in the medical world. I think we are in a unique position in being part of training, and we have such great relationships in Louisville between all of these different providers because they're all training us. So they all have to get along, and
I think
so. It is competitive. It's just y'all have worked out a system to be civil with one another.
I think if you were to ask each hospital CEO about the competition, sure, that's there. But
yeah,
the way I like to think about it, and I hope the way Hannah and Bree like to think about it, is we're a palliative community here in Louisville, and even in the state. You know, I reach out. I have contacts at the University of Kentucky palliative program, and you know, we know the folks. There's another fellowship training program up near Cincinnati, in northern Kentucky. You know, and so you know, I like to think of it more as a collaboration, at least amongst the palliative and hospice communities here in Kentucky. And it really feels that way, really tight-knit community in terms of palliative and hospice docs, because a lot of us did our training here at UofL, and so we know each other, and we work very well with each other regardless of what company we work for.
Yeah, it's good to hear. I was joking, but it's good because, you know, just about any profession, I'm in IT in my day job, and I know IT people at all different companies around the state and some outside, and it's interesting how you kind of build that little community. Even though you work for other places, like you said, you went to school with some people there, and you branch out, but you still stay in touch. And that actually has to be good for the patient because you're sharing information and sharing knowledge, hopefully, because your ultimate goal is to take care of that person.
That's right.
Yeah,
that's right.
So that's pretty cool.
And I think the other thing to highlight, too, is, you know, we're not only taking care of the patient, we're there for families. And I think that's an important aspect, too, is we're supporting everybody we can, because this journey that they're going through is challenging for everybody involved.
So I'm sitting here, and I know you all probably hate talking about the whole pandemic, but since you're inpatient, I feel like you would have seen a huge decline in people not wanting to come in.
In terms of just all the
like
all the
palliative
other
care.
things,
Like I feel
aside
like
from
that's just not like they weren't thinking to come into the hospital, and I don't know. I just feel like there were so many missed patients out there during that whole year. That just didn't. We're scared, I guess.
True. It is true. We still, you know, we also are taking care of patients with COVID, right? Because that
Again, I forgot. I just didn't even think about COVID and stuff like that being a life-threatening, and it is. It's horrible.
It is.
I've seen people like that, but again, I always associate it with cancer, so it's good you brought that up.
Yeah, so we especially, I know we're kind of in the heat of it again. We're on the upswing of COVID cases, but especially about a year ago when it was brand new to us and we didn't know what we know now, very much involved in patients with COVID at the hospital. But we still, I would still say, at least at UofL Hospital, the majority of our palliative patients are not patients with COVID. You know, we still are taking care of a lot of people with cancer and the heart failures and the breathing problems aside from COVID. You know, end-stage dementia is another common one. So yes, I agree with you. I think people have been afraid and delaying seeking care, and then because of that, we might be getting involved because now they're more in the latter stages of whatever it is they're facing.
So how did you get involved in palliative care? Did you go to school to get into palliative care? Did you start in school going down one path and ended up over here because you felt a calling to it? I mean, how did you get involved in because we deal with it a lot. We see the death a lot, and I'll be honest, before we was able to bring some people in, it was having a pretty tough toll on me. So being in that world all the time, is that something that you started going down when you first started going to college and thought that's where you wanted to be?
Go ahead, Bree.
So I initially thought that I was going to be a pediatrician, general pediatrician. That was the goal throughout most of my medical school training, and definitely through undergraduate training. And towards the middle of medical school, when we start our rotations, I did my internal medicine rotation and absolutely loved taking care of adults. And I can remember one patient in particular.
You don't hear many people say that very often.
Yeah, no, that's true. Usually, especially if you love taking care of kids, you're not like, oh yeah, let me take care of adults too.
You had one patient that had an effect on you?
And a little sweet old lady with dementia who suffered a heart attack, and we had discussions with her family, and they were like, we really don't want to undergo cardiac cath and potential open heart surgery, and this is just not the route that we want to go. And she kind of stuck with me. And then I decided to do internal medicine in pediatrics, so it's combined training. So I take care of kids half the time and I take care of adults half the time. Absolutely loved that training. And while I was on my cardiology rotation, again, taking care of patients with really advanced illness and talking through, I don't want to do these things. What other options are there? Because this is not what I want to do. In talking with the patients and the families, and started looking into palliative care, and knew that we had a training program here. Got to work with, as Dan mentioned before, Stacy Mandrola and Kim Pate, who's our fellowship director, and then Dustin Dillon, who works at Hospice with the Courageous Kids team, and just knew that it was going to be the right place for me. So very different than what I thought I was originally going into, but I love it.
Yeah, that's an incredible story, because I tell you, it takes obviously it's a different type of person that can deal with the sick all day. And you mentioned dementia, and that's horrible to watch people lose and forget everything. And I just don't know that I would have the patience to deal with something like that. So hats off to you for that, for sure. So how did you get involved, Hina?
So back in high school, I decided I wanted to be a doctor, and I wanted to be a forensic pathologist.
That sounds interesting.
And be on TV shows. But I ended up matching into family medicine for residency training. And during my residency training, I had some good exposure to hospice and palliative medicine through our inpatient supportive care team in Maine, and had a few cases that really stuck with me, one of which was the pediatric case. We worked a lot in the pediatric ICU as family medicine residents, and really saw the collaboration between the child life specialist, the pediatric oncologist, and the intensivist, just all to work together to help this family who their young child was dying of cancer, and just making handprints and hand molds and things like that, just to make the best of that situation. And then there were a few adult cases as well, where as a family medicine physician, I was able to, they actually did not want to do any hospice or palliative services like outside of just the family medicine clinic. So I was able to kind of journey with them through their cancer diagnosis and many of their hospitalizations, seeing them both inpatient and in the clinic as well. So that really stuck with me, that long ongoing relationship with them. And I got to meet her and got to know her and all of her family members over a 2-year period with her journey with cancer. And then I was able to also have a few cases where since in family medicine, we also do some obstetric care as well. And so there were some cases on the obstetric floor where there were either there were fetal demises or antenatal diagnosis of life-limiting diseases for their babies. And so getting to kind of go through that unique period of life with that mom and that family and that kind of anticipatory grief of knowing that their child is not going to live very long. So I liked that ability to be with people of all stages, like that antenatal stage and the pediatric phase, getting to meet the kids and the family and the other kids in the family, and then also the adults, like helping people in this kind of horrible journey, but finding the moments of joy in that was really powerful. So that's why I decided to do this extra year training specifically in hospice and palliative medicine.
Yeah, that's incredible, especially with the kids. We see it a lot, and it's heart-wrenching. I mean, how do you turn that off when you walk out the door? I mean, how do you get past seeing, especially kids lying there, dealing with that? I mean, is there a way that you turn that off? Is there something that you like to do that keeps your mind off of that kind of thing? Because it's got to wear on you, seeing those kids especially.
Yeah, I think there's certain things that you have to do to take care of yourself. You need to drink water and you need to eat healthy
I like
foods
bourbon myself.
And
I have to try water. I'll see if that works.
And exercise and find out if if you're a spiritual person, finding that faith support. And then just choosing to see the joyful moments. The kids who are going through these journeys still like cartoons, and they still like coloring, and they still like popsicles and being with them, or they like karaoke, and you can do karaoke with them, and those are really high moments when you can do those kid things with them.
What song do you like to sing?
Oh, well.
Be careful. I hear a challenge coming on.
I don't really sing.
Well, I'm really bad at geography, but isn't Maine like the state in the very tip top of the country?
Northeast.
So how the heck did you end up in Kentucky?
I'm originally from
I know.
Illinois.
I always wonder, why do people come here from another state?
Yeah.
Because we're awesome.
Yeah.
Medical people tend to do their training kind of all over. So I'm from Illinois, did my med school training in Tennessee. My husband and I wanted to go somewhere else for, we're both family medicine trained. And then we ended up in Maine. It's a beautiful place to hike and a unique place to train. And then we wanted to come back closer to family. His family lives in Nashville and mine's in central Illinois. So
I've traveled a lot, but she's been in Illinois, Tennessee, Maine, and back here in Kentucky. So yeah. Yeah. So Dan, did you grow up here in Kentucky?
I am. I'm from here in Louisville. Actually, went to Manual and then Bellarmine for undergrad. And
was at Manual last night?
Were you really?
Yeah, my daughter plays volleyball, so
where does she go to school?
She goes to Atherton now.
Okay.
She's moving over to Holy Cross. So,
Okay, good for her.
So UK or U of L?
Really UK. As I've good,
Man,
good.
yeah.
All right.
Well, she's U of L. So.
I was about to say it's good we're separated from each other, but
you got to ask that question. You know, not from here, you probably don't get it. So.
But I will say, as I've matured, I appreciate both schools, right? So, but
I'm
then
not as mean to the other schools as I used to be.
That's
sure.
right. But my wife and I, we met at Bellarmine. She's from here as well, and we left at Louisville in 2007. I went to med school up in Chicago, and then after med school, I was in the Air Force. So my path to palliative care was not as direct as Bree and Hannah. So I did my family medicine residency in the Air Force down in just outside of St. Louis, Scott Air Force Base. And then from there, I went to Offutt Air Force Base, which is in Omaha, Nebraska, and I was on family medicine faculty there.
I didn't know we had an air base in Nebraska.
Right.
I don't think I've ever heard anybody say that.
In the middle of the country. Now, I will say, good plug. Omaha gets a bad rap, but it's a lot like Louisville. We loved Omaha, very family-friendly town. So it was kind of hard for us to leave Omaha. We really enjoyed it.
I've been there I flew in there once for a couple hours, and we had a steak somewhere. It was phenomenal. It's
Really
some
good
steak. That's the only thing I remembered. Yeah.
And then after Omaha, I did a slight detour in terms of what my role in the Air Force, and I went into flight medicine. So I was a flight surgeon for a couple of years. So that's we take care of all the people who fly in the Air Force, and the really cool perk of that job is I get to fly in the airplanes too.
Yeah.
And so that took me out to California. So I was stationed at Edwards Air Force Base, which is about an hour south of Bakersfield.
I've been there.
Yeah, 2 hours by the way the crow flies to LA, more like 5 hours in terms of traffic. But so we spent a couple years out there, and then by that point we had 2 kids. We were the furthest. We made it to the Pacific Ocean, and my wife and I decided it's time to turn back and come home. So at that point, my active duty commitment was up. Kind of that fork in the road. Do we keep going in the Air Force, or do we step away? And obviously we decided to step away somewhat, because now I'm in the Kentucky Air National Guard here as a flight surgeon. So I still do part-time Air Force things, which is great. But then I decided to do my fellowship in palliative care here at UofL. And I don't know, the stars all aligned. I was hired at UofL right after my fellowship. And so the dream continues, I guess. Yeah.
But I'm not hearing that any of you went into medical school to be in palliative care.
I was going to be a cardiologist when I stepped foot in med school.
Yeah.
And obviously
that didn't work out.
Complete 180.
Yeah. Yeah. Well,
I honestly didn't even know that it was a field.
You just wanted to be in the medical field,
medicine,
I guess.
yeah.
Pediatric.
That's what I thought. Yeah.
Yeah.
Yeah. My family had, I guess fortunately, had some good experiences with hospice with some of my family members before I had gone to med school. So I knew about it. I saw the good things they did. I was fortunate enough I think that's part of the problem, and I hope you all agree, is that we don't, as med students going through medical school, and oftentimes even in residency, we don't get a lot of exposure to hospice or palliative medicine. It's just not part of the standard curriculum. But I will say UofL has made it part of their curriculum now. 4th-year med students spend a week with us on inpatient medicine. And then internal medicine residents spend 2 weeks with us as part of their requirements. And then there's some other specialties in terms of residencies that also spend time with us. So it's UofL's, sees the importance of what we do. But for me, I had to seek out some training. In med school, I did a month rotation in Chicago with hospice up there. And then in my residency, a lot of family medicine residencies, I think Hannah's, yours was as well, they're kind of alone in the hospital. Unlike UofL, where you have all these different training programs, where I trained, like we were the only residency in that hospital. So we got to do a lot of stuff. And part of that was doing hospice care in the hospital. So, fortunate for me that I was able to find some of these opportunities through my training, but it's not the norm, I think.
Yeah.
I think the norm of medicine is, preserving life as long as we can. Sometimes even to the detriment of patients and their families of what sometimes we put them through. Mm-hmm. And so I think even sometimes medical professionals also think their go-to in their mind is hospices, we're giving up.
They're skipping you guys.
Yeah.
Yeah.
Rather than, unfortunately, all of us die, and all of us will come to that point on our journey. And hospice and palliative medicine is a way that we as medical professionals can help people in that part of that journey.
Mm-hmm. I tell people death is the only guarantee in life.
Death and taxes.
Nope. I even say not everybody pays taxes, so really it's death. But
I heard
you know,
somebody the other day said none of us are getting out of here alive. So
that's true. So I think we see death as just another part of life, right? Or dying as just another part of life, and that's much like we plan for births and that happy moment, you know, death's not as happy, but we should also plan for how do we want to die.
You know, we had a death doula in here, and I didn't know what that was until she came out, and she was a trip. She was fun. But we talked about death, and he's like, you know, it's just part of life, and we have to learn to celebrate that as long as it's, you know, and it's tough, again, with kids. I just don't get it, but I just think we need to do things differently, and it sounds like with palliative care, you're kind of heading in that direction.
We sure are. You know, one of the things we're, at least personally, that I would like to see us do better in medicine and even palliative care and hospice care is, you know, formally planning for the end of life, right? So advanced care planning is what the fancy name of that is, but we're talking like living wills or medical power of attorneys, like getting on paper what you want to happen to you if you're in a situation where you can no longer communicate to anyone, right? So not only your family knows what to do, but we as the doctors and nurses know what to do for you as well, right?
Do you all work with people in the palliative care to help people with that kind of thing?
We sure
Because
do.
that's what she did, and I didn't know that was a thing. And she, you know, Kelly and I have talked before about when her mom died, her mom handled paying all the bills and all that stuff. Her dad was clueless and didn't know how to do any of that stuff and didn't understand insurance and didn't, you know, and it's interesting that you point that out because that's what she does as well for a business.
Yeah. So, you know, the lawyers out there might not like this, but, you know, living wills, that's its own individual document. You know, I may argue that those are best handled by a physician, right? Because we're talking about what kind of treatment options do you want to have at the end of life, and physicians are probably, maybe not just physicians, but nurse practitioners and nurses, like, we're probably better suited to talk you through that and counsel you on that than perhaps a lawyer. But for a living will, you don't need a lawyer. You just need a notary and or two witnesses to sign it for it to be legal. And those living wills allow you not only to say this is what I would or would not want in the end of my life, but it also allows you to name people to speak for you on your behalf, right?
So as he was saying about my mom, she was 56 when she died. But she didn't have a will. She didn't have a living will. She didn't have power of attorney. We had nothing. It was just my dad and her. But I kind of made all of the decisions, and my dad just had the final say, obviously, as a spouse. But I remember the last couple days of her, she spent a week at UofL, and the doctor had called me one morning and said that, you know, she was dying and we kind of needed to go over some decisions. Well, she had a DNR, but she didn't want chest compressions. And they were like, if you want to be resuscitated, we have to put you on a vent. We have to do chest compressions. Like, it's all or nothing. And she didn't understand that. And obviously in the past couple of days, she wasn't really there. You know, she was so confused. And they were like, we can't do this. You know, like, we need you to make the decision. And so, I had to do that one. But my dad was 17 years older than her. And he was perfectly healthy, still is. But when she died, I said, okay, we are getting a living will. We're getting a regular will. Like, we're doing all of this because you need to know. And I've told my husband the same thing. I'm like, what do you want? If we get in a car crash tomorrow and something happens to you, what do you want to do? You know, I need to know these things. So
very important conversation. So I have a living will. I'm a young guy, relatively young. And I have one, and something that I did before I deployed in the military, right? Because you never know what's going to happen when you're overseas. But like you said, Kelly, anything can happen to us at any time, right? We're never guaranteed another minute. And so, you know, if you're not comfortable, at least in my opinion, if you're not comfortable putting it on paper, at least talk to your loved ones or your friends, your family about what you want done and what you don't want done. And also realize that, you know, if you don't have someone written down on paper legally as terms of who you want to speak for you, you know, there are laws in Kentucky as kind of a pecking order, for lack of better terms, of who we turn to in the event you can't speak for yourself. And each state has different laws. So if you just cross the bridge into Indiana, that's a totally different pecking order, potentially. I don't know Indiana laws, but certainly here in Kentucky, you know, if you don't want one of your children speaking for you on your behalf, perhaps you should get somebody else on paper.
Because I was lucky, like I said. I mean, mostly everything we did, my dad just agreed with me. But it could have been, if I wanted to keep her on and he didn't, I mean, that could have been very bad.
That's true. That's true.
Yeah. Are you laughing about him saying he was young?
Yeah, I was waiting for that. Yeah, we go back and forth because she's half my age. So I was looking at you like, how do you define young? So she's like my daughter.
Do you have a living will?
I don't think I do, to be honest. But you know what I was going to point out is we've got someone that we're working with now. She's a friend of mine, but her mom doesn't even want to talk about it. Her mom is dying. And to be clear, to let people know, you're really hurting the person that is going to be left behind if you're not willing to have those conversations. Because, you know, this friend of mine, she's struggling. She says, my mom don't want to talk about it. She doesn't want to talk about bills. She doesn't want to talk about death. She doesn't want to talk about the funeral. You're really putting that person in a huge situation. If you're not, you just have, and I know, I don't, I mean, obviously my mom died, but I haven't dealt with death myself because I'm still here. But it's hard to have those conversations. But if you don't, you're really hurting the person that's being left here to try and make all those decisions.
I think it goes back what I try to teach the residents. So Hannah and Bree are above, kind of beyond residency, right? But and even what I try to teach the new fellows is being comfortable with the uncomfortable. Mm-hmm. And I think that's where hospice and palliative physicians, it's kind of the niche we fill in medicine, is having these difficult conversations with families and patients. And I think, you know, much like surgeons have the operating room is their place, our place is at the bedside, and we're like I see ourselves as experts in communication. That's what we have to offer people. We have more to offer, but that's kind of our theater, right? Is at bedside talking to people. Hey, this is what's going on, you know, because I think doctors, we could do better jobs with telling patients and families what's going on with their medical care.
We had a whole podcast about that.
Yeah, and I think a lot of times we use, because we like to hide behind medical speak, which the medical community understands what's being said, but patients who are not in the medical field, maybe all you hear is wah, 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 right? And so I like to be the one to go in and really make that doctor speak understandable to everybody, right? And I think that's yet another role we fill as palliative care physicians.
Well, when you said being comfortable with the uncomfortable and kind of about your friend, like I kept telling my mom, because she never wanted to talk about it either. I said, I don't want to have this discussion. You know, I don't want to ask my mom, what do you want when you die, you know, and things like that. And I tell my dad the same thing. I mean, it's not just about you at that point. I don't want to talk about it with you. I don't want to think about you dying, but you have to.
Yeah, because again, another episode we did is how people will take advantage of situations like this. So you're at planning the funeral, and next thing you know, a $2,000 funeral costs $10,000 because they can charge you that in desperate times. So, but that's great that you all pointed that out, because it's very difficult conversation. So you called it fellows. Is that kind of the name of the people involved in palliative care? Are you like fellows, or is that just your way of saying you guys or something?
Just one of the fellows.
Go ahead, fellows. Explain that for them.
So there's kind of a hierarchy, I guess you could say, in medical training. And you're a medical student, and then you do residency. You'll also hear the term intern. So that's your first year of residency training. And then after residency is fellowship. So that's when you specialize in a field of medicine. So we are palliative and hospice medicine fellows. And it's a 1-year fellowship training program. So it's just additional training after you finish residency.
Do you know that?
You can do oncology fellowship.
Wow. Yeah, I didn't know that.
Cardiology fellowship. And so then once we finish this part of our lives, then we'll move on to become an attending.
Oh, okay. So it's
if
the
you
next
hear
level.
the attending physician, that's kind of like
Is
when you finally
the
made it.
attending the kind of grand
You've
poobah
arrived.
of the medical field,
Yeah.
I guess?
You have arrived.
Oh,
That's funny.
yeah.
That's when you get your big kid job and you're finally done with training, except you're really
But
never done.
Yeah,
Yeah.
You're really never done.
you know, there's I've heard through my time. Now, granted, I'm not. I've been practicing. I've been out of medical school now for 10 years. That's hard to believe, but so oftentimes people in training, residents, they'll say, "Oh, well, I'm a PGY1, so postgraduate year 1, 1, 2, 3, 4, 5, whatever it might be," and I meet doctors who've been out practicing for years, 20, 30 years, and they're like, "Well, I'm just a PGY 40, right?" So because it really is. It really is. You never feel, and I don't think we as physicians should ever feel comfortable and just like we know it all, right? I liken myself, if you ever read or watched the Game of Thrones, right? The throne that the Lancaster sat on was intentionally made uncomfortable because, you know, they never wanted to, the idea was to never be comfortable with what you're doing. And I think being in that, having that mindset really pushes us to continuously learn and hone our craft better.
I just feel like medicine changes every day.
Say it again.
I feel like medicine changes every day.
Probably every minute.
Yeah.
I mean,
There's just nonstop.
everybody now, I think, at least I hope, sees how quick things change with the COVID pandemic, right? We went from knowing absolutely zero to now knowing quite a bit, probably not all, but you know, you kind of see how that evolution happens.
Well, it's been great having you all here. I think we learned a lot today. I did. And you had mentioned one thing that you would like to get out there is people need to contact you all earlier. Is there anything else that you would like to get message-wise to people that might be considering this path? Is there anything else that you'd like to get out there?
Definitely, yeah. Ask about us when you're at the hospital. Ask your doctors that, you know, what about palliative care? What about hospice? It's not a bad conversation to have. You know, it's at the very least it's just a conversation, and that doesn't hurt anything, right?
And it doesn't have to be just when you're at the hospital. Talk to your primary care doctor about it. Talk to your oncologist about it. Palliative care, like we've said, is definitely a way for us to walk alongside of you, and you don't have to stop any of the things that you're doing. We're just here to provide an extra layer of support.
And also, it's never too early to think about what you would want and complete one of your living wills or advance directive.
I think that's the key. Again, and I need to do it. Kelly put me on the spot. She made me feel guilty. I don't have that, but I consider. Yeah, I know. She thinks I'm old, and I'm getting there. But you just don't think about that things, and then then it's too late. You know, you see people in a car crash, and they're trying to do the living will stuff, and it's just at that point nobody's thinking clearly. So.
Talk to your family, though. You know, for anybody who, if you don't feel comfortable writing stuff down, talk to your family so at least they know what you would want. And they can think back to those conversations if they get in that position. I
want to party though. I don't want to. I don't want to lay there in a casket and everybody crying around me. You know, I want to party.
But do you want all of the life-saving things, the vent and all that? That was the big one.
I don't know. You know, if there's no going back and I'm just going to lay there for the next 10 years and not be functional, no, I don't want to be around.
Yeah, so we often refer to that as existing, right?
Yeah,
do you want to exist on life support?
Nope.
And yeah.
No. So. All right, I'm going to look up the living will stuff.
Good.
You can plan your party too if you
want.
Right?
We talked on another episode that a new business model, and somebody pointed out that it exists, but a funeral home with a bar, and everybody, you know, have a keg party and have some fun, not stand around and cry the whole time.
It's a life celebration.
It really is, yeah.
It's
and then actually the death doula pointed out that that's what people used to do. Yeah, she said she helped plan a Viking funeral, but I didn't realize this, but a lot of those big homes built in the 1800s, they had a parlor in the house, and that's what the parlor was for, was to lay people out when they pass and the family come by and visit and party, have a good time. But somewhere we turned the direction on sadness and playing horribly god-awful slow songs at these funerals and everybody passing around Kleenex, and I don't want that.
The funeral director right now is listening to you, and he's not very happy.
Or he or she is taking notes on how to expand
in.
their business.
That's a good idea. There you go.
Well, thanks so much for coming in. This has been great, and it's amazing what you all do. I don't know how caregivers, we see enough of it with what we deal with, and I don't know how caregivers do it every day, but hats off to you all. That's amazing.
Well, thank you very much for having us. We were honored to be here.
It's nice to meet you all.
And nice to meet you.
Kelly, wrap it up. How do they help?
Sure. What are we in? Almost October now. So for 2021, we were pushing really hard for 1,000 $10 monthly donors. And I think we're almost there money-wise. We've had a few small businesses donate $100 a month, so we appreciate you all there. But if you're looking for a charity to support or, an end-of-the-year donation, please consider Shirley's Way. You can go to our website at shirleysway.org to learn more. Thanks.
Have a great
day. See ya.
See ya.